Okay, it's one of the most frequent chief complaints in children under 3 years old, and also 10 to 20% of pediatric visit to emergency department in US. Actually, I can say that, in the Children's Medical Center, this percentage is more than what you can see here. And I don't know if you have participated in these clinics or not, but fever, I can tell you that it's about 50% of pediatric visits. And also 20% of these will have no localizing source, which we'll talk about today. At first, I want to talk about definition of fever. Fever is increase in body temperature over normal daily fluctuations, accompanied by increase in hypothalamic set point. As you know, central body temperature naturally fluctuates around half to 1 degree, with a minimum in the early morning and a peak in the late afternoon. So the body temperature is higher in the afternoon and it's normal. And the mechanism of fever is elevation of hypothalamic set point in central nervous system by external febrile substances like infections, collagen vascular disease, malignancies, or it can be due to generating more heat than it dissipates, like salicylate poisoning, hyperthyroidism, high ambient temperature. I will talk about high ambient temperature. For example, families like to put a lot of clothes and blankets to their children, especially in neonates. And after you examine the child, you should rule out the high ambient temperature. It's very important. You can decrease the number of clothes, and after, for example, 1 hour, you can, uh, uh, I'm sorry, something happened. Okay, and after decreasing the number of clothes, you can measure the temperature, and if it's now okay and decreased, then you can decide that the high temperature of children is due to high ambient temperature, and nothing important is happening. Another cause of fever is heat dissipation disorder. Like, in patients with ectodermal dysplasia, hyperthermia caused by taking certain medications. As you can see here, exogenous pyrogens can cause the body to produce endogenous pyrogens, and after that, the production of prostaglandin 2 and hypothalamus, and after that, we have fever. As you know, fever is one of our immune mechanisms in front of, bacteria and viruses and infections. So, it has some benefits. Impaired replication of microbes enhance phagocytic bactericidal activity, and also glucose metabolism decreases in favor of that based on lipolysis and proteolysis, actually depriving bacteria of favorite food. And also hepatic production of acute phase reactant proteins bind divalent cations, which are growth factors for microorganisms. And you should have these benefits in your mind, and we shouldn't, treat any fever. We have some methods of measuring fever, like touch is, not acceptable, and also using a thermometer, oral, tympanic, rectal, axillary, or forehead. In this table, you can see normal body temperature. If you measure by rectal devices, up to 38 Celsius is normal. In mouth, up to 37.8 Celsius is normal, and in axillary, up to 37.5 Celsius is normal. You should know about it. And here we have methods of measuring the fever. Birth to 2 years, the first choice is rectal. Between 2 and 5 years, also rectal. And older than 5 years, the first choice is oral. And also, in the thermometer that has mercury, we should, be aware about it. Maybe it will broke and something bad happens. So we use the rectal and after that oral in children older than 5 years old. Okay, so fever is a symptom, as you know, not a disease. In most cases, fevers are benign and short-term, nothing very important, and it's generally not related to the severity of the disease. And most of the time, what bothers parents is fever phobia. There is no evidence that children with higher fevers have worse prognosis. So you should have all of this in your mind when you are practicing and visiting a patient with fever. Actually, many parents, have phobia of fever, so you should calm them down and talk to them. Here we have antipyretic drugs that we use them. First of all is acetaminophen. Yet the dosage in the children is 10 to 15 milligram per kilogram of body weight every 4 hours, up to 5 times a day. Our second choice is ibuprofen, 5 to 10 milligram per kilogram of body weight every 6 hours. And aspirin, actually, we don't use it routinely because of the chance of Ray's syndrome in children. So the acetaminophen and ibuprofen are important for you to know the dosages and how to use it. Okay. When we're visiting a children with fever, actually, at first, we should confirm the existence of fever. Many parents measure the fever with touch, and it's, not accurate. And we should confirm the existence of fever with the thermometer, and we should ask about duration of fever and also accompanying syndrome. Okay, we should see if the child is seriously ill or not. And if he or she is ill, is there any obvious source of infection or not? Also, some past medical histories are important in children, with past history of diseases like HIV, sickle cell, nephrotic syndrome, and rheumatic fever, because the chance of some special infections in this patient will improve, and you should know about it. And also we ask about current illness like duration and type of fever. For example, in some diseases, you have fever in every 2 or 3 days, or for example, it peaks in some special hours in a day. So you should ask about it, and also about consumption of water, for example, dirty water sources, and also living conditions about rats, fleas, plague, and leptospirosis are also important differential diagnosis in these cases, and also about infectious contacts like TB and influenza. And also nowadays, COVID-19 should be at the first. Okay, and I want to talk about physical examination. There are some important points in the physical examination that we will read together. Based on the history and examination, the patient actually is categorized in one of these following groups. Fever plus obvious danger signs. As you know, we will hospitalize this patient. And after the second group is fever plus localized symptoms and signs. And management of these patients are easy because you know the source of fever and you know what to do. And Atlas fever without danger signs and local symptoms.
Dog?
Uh,
Oh, okay, okay. I wanted to ask you this. It's okay.
yeah, ask me if you have any question.
I wanted to ask exactly what you just opened. I wanted to ask you what are the obvious danger signs. So you just
Yeah.
went on there. Thank you.
You're welcome. Actually, the danger signs are decreased consciousness, convulsions, neck stiffness, respiratory distress, symptoms of sepsis, and petechiae purpura and ecchymosis. Actually, one of important differential diagnoses is meningitis, and we check the level of consciousness and also encephalitis and convulsions, neck stiffness. For this differential diagnosis, also respiratory distress is very important. In children, even if the respiratory syndrome, is not related to the fever and to the disease, you may have tachypnea in the children, and you should notice this. Also, symptoms of sepsis, like, for example, blood pressure, the vital signs you should be aware about, and petechiae purpura, ecchymosis, also other important differential diagnosis like meningococcemia. So, you should examine the patient very well. And there are some local syndromes. As I told you, the importance of local symptoms is that you can understand the source of the fever, and your management and follow-up will be easier. For example, if it's related to nervous symptoms, systems, or respiratory symptoms that are related to, for example, respiratory symptoms like, for example, viral pneumonia, bacterial pneumonia, bone and joint symptoms. The differential diagnosis, for example, are osteomyelitis and things like that. Urinary symptoms. The important differential diagnosis is UTI, gastrointestinal symptoms. Then, the viral or bacterial differential diagnosis, and also skin rashes is very important and common in children. Here, I brought some important, diseases, like I just read them. You should have them in your mind when you are examining the child: meningitis, encephalitis, otitis, sinusitis, mastoiditis, pharyngeal abscess, upper respiratory infection, pneumonia, arthritis, osteomyelitis, soft tissue infection, and lymphadenitis. As you know, each of these diseases have, its own symptoms and signs, and you should examine the patient very well. Here is some differential diagnosis of fever and rash, like herpes simplex, chickenpox, hand, foot, and mouth disease, measles, rubella, infectious erythema, Rosola infantum, scarlet fever, Kawasaki, and infectious mononucleosis. Can anyone tell me an important aspect of Rosola infantum rashes and the relation between fever and rashes in this disease? I can't hear you. Sorry.
I think the fever lasts for three.
Can you talk louder?
the fever lasts for 3 to 5 days, then the rash comes. It's like they don't happen simultaneously.
Yes, very good. Exactly. After, the end of the fever, we have rashes, and after that, the rash will be ended. Here, I don't want to read this, but I brought this for you. You can take a picture or have this in your mind. Usually, if you want to examine your children, you should have this in your mind, so you can read them after the class by yourself. Here, I want to talk about the approach in fever. As you know, different ages in children are important for us. And our approach will be changed by the age of the children. Also, duration of fever is very important, and underlying disease, also vaccine status, and also endemic disease or travel history is very important. Can you tell me some examples, for example, for underlying illnesses that you can tell me a disease and also? Okay, tell me, someone wanna speak? No, there isn't any answer. Okay, for example, in patients with HIV, you should think about, for example, about PCP in these patients, especially when their lungs are affected. Another thing is, for example, vaccine status in Iran. We don't have a pneumococcal vaccine for general population. If you want to vaccinate your children, you can go by yourself and buy the vaccine and inject it. But we don't have it in routine and for popular people. So the chance of bacterium with pneumococcus is higher than other organisms. For example, we have a vaccination for Haemophilus influenza, so the chance of infection with these organisms get lower in these years. So at first we should be aware about pneumococcus in Iran. And endemic disease also, we have the pandemic of COVID, and the importance of it. Travel history is also very important because of viral gastroenteritis or other diseases. Okay, if we have no danger signs and local symptoms, then if the fever is less than 7 days, and we don't have any local symptoms, then it is called fever without localizing sign, or FWLS. Actually, normal history, clinical examination, and then we will talk about different ages. So if your up to now, if your children have danger signs, you should hospitalize the patient. And if the general situation is good and you can find local symptoms, based on them, you can manage your children. But there is some situation, for example, you have fever, but you can't find any localizing sign and you don't know what to do. Here, I want to talk about it based on your child's age. And after that, fever lasting more than 8 days, we call it FUO, fever of unknown origin. Actually, history, clinical examination, and initial tests are normal. Okay, at first, fever without localizing signs. Uh, if your child is before 1 month, then you should hospitalize and do the sepsis workup, send the laboratory tests, and you should start empiric antibiotic therapy. But before that, as I told you, high ambient temperature is important here. You should first rule out the high ambient temperature and have it in your mind, especially if your neonate is good and the general situation is okay. And before okay, and after that, between 1 to 3 months, if your child is toxic, then you should hospitalize it. Or after that, if the child is non-toxic, you can check CBC differentiation test, send blood culture, UA, and something important here is ask about past history of prematurity, meningitis in other siblings, or any other disease. If any of them are positive, you should hospitalize your patient. Actually, this age is borderline. You should think about everything and general situation, the situation of parents, and decide what to do. But if your child is non-toxic, you can wait, check, for example, CBC, send blood culture, UA, and decide after, the results. But also, if you hospitalize the patient, there isn't, any wrong things in this, and you can hospitalize too. But if the parents are good and they can follow up well, you can send this lab and follow up the patient. Here is, the algorithm for evaluation and management of fever in infants and children more of age. As I told you, it's up to you in this age range, and you should decide. Here, you can see risk factors for urinary tract infection in children 2 to 24 months of age. In female, the risk factors are white race, age below 1 year, temperature more or equivalent to 39 Celsius, fever duration more than 2 days, no obvious source of infection. And in male, uncircumcised boys at higher risk, non-black race, temperature more than 39, fever duration more than 1 day, and no obvious source of infection. It helps you to decide that, for example, you want to examine the children and you don't know what to do. You think with yourself that I want to hospitalize or no, I can send the labs, and after that follow up. If your child have these risk factors, then you can decide better. And for example, you can send urine analysis for your child and wait for the results. In the age between 3 to 36 months, if your child is toxic, then you should hospitalize. After that, if he or she is non-toxic and fever is below 39, then you can follow up in 24 to 48 hours. And if the fever is more than 39, you can send blood culture, CBC, urine analysis, and start antibiotic therapy. In children, you can use, single dose of ceftriaxone and intramuscular for them. But important thing is that before that, you should send this lab. And you can follow up the patient with their blood culture. And in the CBC, the important things is leukocytosis. The white we see more than 50,000 is important for us, and it can shows an important infection. Okay, fever with unknown origin. The causes are infections, collagen vascular disease, and malignancies. These are some of more important causes of FUO. In infections that causes FUO, the important things are TB, typhoid fever, brucellosis, infectious endocarditis, rheumatic fever, abscess, and chalazia. And also in the collagen vascular disease, you should examine the patient very well and ask about other symptoms in arteries, rheumatitis, on other many differential diagnoses. And at last, the malignancies is very important. You should, you can ask for other labs and examine your patient. For example, examining the abdomen for organomegaly or other things. And at last, if you have any question, I'm here to answer you. Thank you very much. You can raise your hand or open your microphone to talk. Or if you
Thank
have...
you, Prof. What are like the common tests which we do for sepsis workup?
Actually, the important tests are a CBC, and you should have the exact, for example, number of neutrophils, lymphocytes, and other cells. After that, you can ask for CRP because it rises, in infections, and in prolonged fever, the number of ESR can help you. After that, you can ask for urine analysis. If your child has, for example, diarrhea, you ask for a stool exam, a stool culture. If you have respiratory distress, the X-ray of chest is very important. And most important of them are these. And very, very important is blood culture. You before starting the antibiotic therapy, you should ask for blood culture.
Thank you.
You're welcome. And if you have any experiences with children, actually with fever, I will be glad to hear you. You can tell us. You don't have?
For me, I don't have.
You don't have? Have you been in a children's medical center ever or not?
I was there.
You were there?
Yes.
Yeah. You can see there are many patients with different, chief complaints, and I think it can be a very good experience for you. Okay, at last, thank you very much for your participation. If you have any question, you can ask me. I will be glad to answer you. Thank you very much.
Thank you so much, Professor. Have a great day.
Thank you. You too.